Hello, welcome to our webinar today. My name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. And today's event is entitled The Evolving Landscape of Nursing, RNs in Public Health and Long-Term Care. Let me go ahead and introduce you to today's presenters. Today, we're joined by Paula Kett, the Assistant Deputy Director at the Center for Health Workforce Studies and an acting assistant professor in the Department of Family Medicine at the University of Washington. We are also joined by Betty Bekemeier, a professor in the School of Nursing at the University of Washington and the director of the Northwest Center for Public Health Practice at the School of Public Health, also at UW. And finally, we're joined by Joanne Spetz, the director of the Philip R. Lee Institute for Health Policy Studies and the director of the UCSF Health Workforce Research Center on Long-Term Care. And all of that is also located at the University of California, San Francisco. Welcome all of you. And at this point in time, I'm going to go ahead and turn the event over to Paula. Paula, would you like to share your screen?
Morning all, or morning for us. It might be afternoon for some of you now. Betty and I are excited to be here with you today to share a little bit. Betty's going to start out and talk a little bit about an overview of where we are with public health nursing research, a little bit of a state of the science, and then I'm going to finish out deep diving into a study we did looking at a different way to measure the public health nursing workforce. So I will hand it over to Betty.
Great, thanks, Paula. Good morning, everybody. It's great to be here. So to give you a little bit of context about what we're going to be talking about, here's a slide from NACCHO, that's the National Association of County and City Health Officials, regarding changes in the local public health workforce over time. The folks in public health circles talk about this all the time, that the size of our workforce has been dwindling nationally over the years. Folks talk about this a lot. Perhaps it's no surprise to you. And this has been going down, down, down over recent years. And until mostly during the pandemic has been a bit of an upswing. Then by now after 2022, this slide goes up to 2022. It does show some overall increasing, but frankly, it's dropping again. But that said, next slide, Paula, thanks. So this slide only goes until 2019, but it breaks up these workforce changes by discipline. And in this graph, you really see what has generally been driving this overall workforce decline, and it's nurses. It's nurses in the public health workforce. And this only goes up to 2019 in this slide, again, from the National Association of County and City Health Officials. But the 2022 data, not shown here, still has RNs decreasing down to a little over 20,000. So, and this is even after as the overall public health workforce has been increasing. So with that kind of context, it makes you wonder, is this okay? What does this mean for public health protection, health promotion in our country? So I'm going to spend the first part of this talk discussing, what is the state of the science around public health nurses, and to help situate the study that Paul is going to take a deeper dive in. But this we'll hope to give you a bit of insight about how we need to go about building the evidence of what do we need to know and what do we need to still better understand. So Paula and I and others often get asked if we can provide data or evidence that show public health nurses matter. And you can see why that's a big question. And the reality is we do have some evidence that demonstrates this. But to answer that question well, there is a host of other data and research that's needed. And we'll briefly lay this out for you here. So this slide here kind of gives you a sense of, we'll just touch on some of the research in these different areas. Who are public health nurses? They're meaning the demographics, the education background, and where are they? How are they distributed? particularly, in terms of their setting, where they work, their rural and urban location, et cetera. What do they do? How do you nail down their functions and activities and specialties, especially when, their work is really on a population level, their patients are a whole population. What do they need in terms of training, support, recruitment, retention? How do we fill gaps? And how many do we need? We don't even really know. We haven't really known how many there are. So how many we need is a hard question to answer. And then most importantly, this question is, why do they matter? The question of their value. So are outcomes better when they're around? Questions are often getting at health outcomes, but we're also interested in things like organizational performance and workforce related outcomes. So briefly, some of the research that has been done around questions like who or where are public health nurses, and in these introductory slides or overview slides, I'm going to be talking about existing research. Sometimes some of it is very new, some of it is work that Paula and I have been privileged to lead, but others as well. And there'll be a reference slide at the end. So first, who are we? Where are we? Where are those public health nurses? As I mentioned, the size is really decreasing over time. We were part of an enumeration effort last year that produced some papers around that, really trying to get a handle on the actual numbers. And when you broaden out, when Paula and I have been able to broaden out the idea of nurses working outside of traditional, what we think of as traditional public health nursing settings, like in health departments, and broaden that out and include those in public health, school health, corrections, et cetera. We found they still make up less than 4% of the overall nursing workforce nationally. So it's a tiny part of the larger workforce. Demographically, it's majorly people identifying as female, identifying as white. It's an aging workforce, mostly bachelor's prepared. Approximately a quarter of the PHN workforce is in rural areas. So they're heavily in rural areas in particular. And the states with the highest proportions of public health nurses in their overall workforce, the RN workforce, is in Minnesota, North Dakota, and Alaska, interestingly. So what do? They work on this population level. We've been trying to get a handle on public health nursing work going beyond this idea of just looking at where they work and calling them a public health nurse, but instead looking at the roles and functions. So thereby uncovering public health nurses that are doing public health nursing type of work, but often in different kinds of settings. But in terms of their roles, they are health department directors, they're nursing directors, they're frontline public health nurses, consultants, researchers, et cetera. The kinds of functions that really relate to some of their work, the research has shown is care coordination, really bridging this integration of public health and primary care, quite often doing population health, population level strategies, health promotion, prevention. They're in a lot of leadership roles, providing strategic direction, partnership building. They're really active and effective in partnership building, assuring strong relationships and community. And some of their specialization in the surveys of the public health departments report these nurses working in maternal child health, communicable disease, school health, and clinical services. And in broader nursing surveys of the broad nursing workforce, most report they're specializing in school health, public health, or correctional health. So why do they matter? And this is about what public health nurses bring to public health and what they bring to the nursing workforce overall and their impact on communities. And we have citations here that relate to, nurses as bridge builders, as having a broad, unique knowledge base of populations and communities. That nurses in leadership in public health settings really have an emphasis on social terms of health and policy making. They also bring the systems perspective, very strategic in their leadership. We've found, Paula and I, that they bring unique skills to emergency preparedness and response. Another colleague of ours has shown their work in climate justice. So, and we found that nurse leaders that in health departments in particular, not just they don't have just an impact on other nurses in their agencies, but on the whole workforce in their agency overall. So their whole workforce, their whole agency is as a higher level of competency and proficiency, et cetera, than when they have a nurse leader in their health department. That even the health outcomes in those communities are better. So what do they need? There are still, what do we see as ongoing needs for this workforce? We need to strengthen education and training, professional development. They need more work in terms of how to use data to inform their practice. There needs to be a lot better education about the PHN role, not just in nursing, but in broader public health circles, and helping these nurses work to the top of their scope of practice. And finally, this question of how many do we need? This is a really sticky question that really has not been answered. A colleague of ours, Dr. Casey Balio, recently did some work on, and she's part of our CWARF consortium for public health workforce research, and has done some recent research on looking at a PHN need index. So Paula and I hope to do some further work around that and look at what does that need and supply index, how does that impact levels of specific health conditions in communities relative to their supply. But folks talk sometime about wanting a public health nursing ratio. We kind of push back on that. We don't want there ever to be a notion either that they're not needed in some communities, because there's no evidence of that. So anyway, that's my quick overview. I'm going to pass it over to Paula to sort of dive deeper into some other work.
Yeah, thank you, Betty. So as Betty kind of foreshadowed a little bit, we have often ways that public health nurses are measured is by setting, so kind of where they work. And our kind of concern with that is it doesn't necessarily capture all that public health nurses do. And depending on the setting that's chosen, it may miss nurses doing public health work outside of that setting. And so generally, we've had a difficult time assessing public health nursing distribution because of this. And there are varying types of surveys that can capture nurses in public health. There's public health surveys, but that's typically governmental public health nurses. So it's limiting them more to this governmental space when measuring. Or in national nursing surveys, limiting nurses who pick public health as a setting, for example. But knowing that there may be a broader way or a different way of trying to capture and measure public health nurses instead of just by setting alone, both for understanding what they do and for supporting workforce development. Another area or gap in the research is that studies on nurses in public health rarely are including public health nurses in federal agencies, such as those in the U.S. Public Health Service, Commission Corps. And so this study kind of tried to bridge both of those gaps. We had an opportunity to work with the U.S. Public Health Service nurses. We worked with the current chief nurse, Admiral Jennifer Moon, and then Dr. Aisha Brooks, who's the former chief public health nurse in the U.S. Public Health Service. They had a real interest in just a study looking more deeply at the Commission Core, who are they, and that sort of thing, and also gave us this opportunity to test function and activity questions. So the study both describes the group, refer to this group of nurses as public health nurse officers from now on, just to shorten that a little bit, and to test. The second aim was really to test these function and activity questions to get more at what do public health nurses do rather than just where they practice. Okay. So we developed a survey that really adapted for most of it existing national nursing survey questions. This survey had 4 sections: nursing education and background, position and job information, and demographic information. And some of this was very specific to the nurse officers in the public health service, particularly position and job information based on their titles. And then job roles and functions was a section that we developed using the public health nursing scope and standards, public health taxonomy, as well as vetted and reviewed with other experts in the field around public health nursing. We conducted this survey in early 2024, and we invited every nurse in the public health service to participate. So as we said, that was approximately 1,200 nurses. We conducted a descriptive analysis just to provide an overall description of the nurses in the sample, but then we also divided the sample into primarily clinical and primarily non-clinical groups. And this was really because the nature of public health service nursing work is a lot of their job is to fill gaps in the health system. And so a good proportion of them are working in more primarily clinical settings, such as ambulatory care, rural health centers, and hospitals. And that is different work than public health nurses generally are doing who aren't working in the federal space. And so we separated out these groups and created kind of a primarily clinical group, mainly in the hospital settings, and primarily non-clinical group in settings that were more aligned with public health nurses more broadly in the US. Okay, so we had a great response rate. About almost 50% of the sample responded, 565 nurses. Most identified as female, as being above 40 years of age. Just under half identified as white, about a third as African American or Black, and 14% as American Indian or Alaska Native. And almost half said that they had a master's degree in nursing as their highest nursing degree, about 12% with a PhD or a DNP. And of that 12%, about half of them reported a public health focus for their PhD or DNP degree. And just as a note, a bachelor's degree is required to be eligible to be a nurse in the public health service, so everybody had a bachelor's degree in the sample. Respondents reported having worked as a nurse for about 19 years and in the Commission Core for about 12 years on average. So with respect to agency, we asked them about where they worked, setting, program area, et cetera. And here we can see that most respondents reported working in these top 4 agencies here: Department of Health and Human Services, Department of Homeland Security, Federal Bureau of Prisons, and Food and Drug Administration. But a wide range of agencies, as can be seen by the full list here. We also asked about primary program area. This was the full list, with most reporting correctional health, ambulatory, or some sort of administrative type work. With respect to the function and activity questions, the kind of majority reported functions in these top 5 areas. So health promotion and protection, clinical interventions, care coordination and case management, policy and advocacy, and research, evaluation, and quality improvement. Most respondents, 88%, agreed that the function and activity questions did accurately describe their work. Approximately 12% identified their main functions as other initially. We were able to recategorize most of these into existing function and activity questions. But we did find that with some of these, it identified a need to expand some activity options or to increase clarity around the description of what some of these top areas were. When we looked at the primarily non-clinical and primarily clinical group, we found some major differences in reported functions, with a higher percent reporting of the non-clinical group reporting functions in research, evaluation, quality improvement, in policy and advocacy, and in enforcing laws and regulations. So that non-clinical group is that lighter gray, lighter color as opposed to the darker. And then when we're looking at the primarily clinical group, we can see there that there's quite a large difference in the proportion reporting clinical interventions, as well as more case management, care coordination work. So overall, we find that public health service nurse officers are quite diverse, highly educated, and more diverse and more educated than the general nursing population based on existing information. In our sample, approximately 30% identified as Black and less than half as white. And this as compared to in the national nursing population, about 10% identify as Black and 63% as white. And then a high 12% of our sample reported a type of doctoral degree, either a PhD or a DNP, and this is more like 3% in the general nursing population. So just offers potential opportunities for learning in terms of recruiting and retaining a more diverse nursing workforce more broadly. We did find that overall proposed function and activity questions accurately captured the responsibilities of nurse officers, but do find that there may be some areas of needed clarification or expansion in testing these questions. And then just two kind of final recommendations is that knowing that these were accurate, we would recommend that these questions are piloted in this study would be used for future assessment of the PHN workforce in conjunction with surveys assessing the larger public health workforce and national nursing surveys. And that there may be opportunity to modify or add questions specific to respondents' work functions when measuring the nursing workforce to better understand the role of nurses and better capture smaller specialties. So thank you so much. We do have a paper on this, so this is the information about that. And thanks so much to our team and the nurse officers who contributed. Our work was supported. This was part of the CWRF project last year. Here's our contact information and references from the research overview that Betty shared at the beginning. Okay, and I will stop sharing and hand it over to Dr. Joanne Spetz to talk about the long-term care workforce. Thank you.
Great. Hopefully my slides are showing now. I see nodding heads, which is wonderful. Okay, great. So I'm going to talk today about a different aspect of the registered nursing workforce is those who are working in the long-term care settings. Clearly there's interest overall in understanding the many, many diverse settings in which RNs are serving, public health nursing being one of the, quite frankly, least studied until some of the work that Paula and Betty have been doing. We know a little bit more about nurses in long-term care, and I'm going to share some recent results from some work that I've been doing with Tim Bates and Laura Wagner, who are also with our Health Workforce Research Center on Long-Term Care. So I'll begin with a little bit of background. Starting with that, registered nurses are the largest group of licensed nurses in the United States. As we know, there are about 4 times as many registered nurses as physicians in the US. And you find them everywhere, the most common setting being hospitals. Depending on the year of the survey, really over the past 30 years, it's been pretty consistently between 60 to 65% work in a setting that would be associated with a hospital. what they might be doing in the hospital is shifting over time. They might be doing more work in an ambulatory care setting associated with the hospital, but the overall paychecks are coming from hospitals or hospital systems for most RNs. Now, this study is what we do know from the research is that RNs who work in long-term care settings earn less than in hospital settings. And this study is going to look at what are the demographic and the human capital, or kind of skills and knowledge characteristics of long-term care versus non-long-term care nurses, and what are their earnings today? Because of course a lot of the literature is older, so we wanted to make sure that we're up to date in understanding this workforce. So we used for this the National Sample Survey of Registered Nurses from 2022. So I should have noted that this is the most recent release of the National Sample Survey of Registered Nurses, which is, the flagship survey of the nursing workforce in the United States that began in 1977. So a lot of research has been done with these data. It's a treasure trove for those of you who haven't worked with it. The population that we're focusing on in this analysis are the registered nurses in the data, so excluding nurse practitioners who were employed in nursing as of December 31st, 2021, which is the reference date in the survey for reporting employment, that were active in patient care and didn't have advanced practice training, as I mentioned. And we defined long-term care as being employment in a skilled nursing facility or nursing home, rehabilitation or long-term acute care, home health, or adult day services. So that's 9% of registered nurses that reported that they were working in one of those settings. And we started with some descriptive analysis of the population, which I'll tell you about, and then we also did some multivariate wage models to understand the different factors that had the most influence on wages. So let's start with some demographics. I think one of the things that's very interesting and has shifted over time is that there was in 2022 no difference in the racial and ethnic composition of long-term care versus other RNs. It was true in older surveys that long-term care nurses were more likely to be Black and Hispanic in particular, and somewhat more likely to be Asian. And that really has shifted, which is in and of itself a really interesting change in the patterns that we've seen. Another pattern that we've seen over time is the age distribution. Nurses working in long-term care themselves tend to be older than nurses working in other settings. And that was a statistically significant difference. And then the last row, you've got the rural residents, and nurses working in long-term care are also more likely to live in a rural community than nurses working in other settings. So what about their educational differences? The initial education that they enter the profession with is different between long-term care and non-long-term care, notably that the non-long-term care nurses are much more likely to have a bachelor's degree than are the long-term care registered nurses. The initial education program for long-term care nurses is also significantly more likely to be from outside the United States, which is interesting because in general, internationally educated registered nurses are more likely to have a bachelor's degree. But even though internationally educated nurses are kind of overrepresented in the long-term care nursing workforce, still the bachelor's degree is kind of underrepresented relative to the full RN workforce. The rates of current enrollment in an education program are somewhat higher for nurses not in the long-term care setting. This is probably correlated with the younger age of the non-long-term care nurses. And nurses in long-term care were nearly twice as likely to have been previously licensed as a licensed practical nurse or licensed vocational nurse, which is a very, very big difference and was definitely statistically significant. And here are the circles for those other points. So what about their employment patterns for those working in long-term care versus not? I think one of the interesting things that has evolved more recently in the data is that long-term care registered nurses are somewhat more likely to be working for an agency than are nurses in other settings. And that really has been a shift compared to prior years of data. In terms of position titles, the long-term care nurses, registered nurses, are also more likely to report that they're in a management job title. And they are more likely to report that they are in some other job title. And I will note that other in the job titles reported by the survey includes home health nurse. So that kind of makes sense, that given that home health nurses are part of our data, that they would be categorized, they would say their job title is home health nurse. In terms of union representation, the non-long-term care nurses are much more likely, more than 3 times more likely, to report that they're union represented. And the job changing rates are actually very similar between the long-term care and non-long-term care nurses, which is that bottom row. So we wanted to look at, kind of holding all these different characteristics equal. What are the strongest predictors of working in long-term care? So we estimated a logistic regression, which is basically a regression where the outcome is, do you work in long-term care versus not? And then we controlled for the demographics that you just saw, and the human capital variables, which a labor economist would define as the highest education, international education, current enrollment, prior licensures and LPN, and then we also included military service, either current or past military service, because many nurses come through the military nurse corps. So this chart depicts the predictors of working in long-term care from that model. The dots are the predicted predicted change in probability for that variable being true or false. And then the bars give you the sense of how confident we are of that estimate. It's the confidence interval. So the strongest predictor in terms of the marginal probability was international education, which isn't surprising given the data that we just saw. People who are internationally educated, controlling for everything else, are about 6 percentage points more likely to be working in long-term care. The second most common, or kind of second most influential factor, was actually being age 65 and older. Now, on the surface, you might think, like, how many nurses 65 and older are actually working? And it turns out a fair number are. It really starts tapering off much more steeply after the age of 70. So there are a fair number of older nurses that are working in these settings, which means that they're bringing a wealth of experience to their work. It also means that there may be more risk in long-term care settings of impending retirements. The next most highest was age 55 to 64. So as what I said before about impending retirements, this might raise some concerns for this sector about that. Also high, we basically have a consistent trend with older ages being more likely to work in long-term care, controlling for all the other factors, which is consistent with what the descriptive statistics showed. Previously working as an LPN or LVN also are strong predictors, but the marginal probability, the change in probability, is not as big as the other variables like age and foreign education. Rural residents, also, again, it was a big difference in the descriptives, but not as big when you control for all the other factors. So what about the negative predictors? Not surprisingly, bachelor's degree and master's or higher degree, both were statistically significantly strong negative predictors of working in long-term care. So as I said, we also wanted to look at predictors of hourly wages. And so we started with just describing the wage data. And then we estimated a wage model very commonly used in the labor economics literature, where the wages are typically in log form to address any skewness in the distribution. That conveniently also means you can roughly interpret the coefficients as percentage changes. And we controlled for pretty much everything you saw in the prior regression models. And we included variables about their employment, agency employment, their job title, whether they were holding multiple jobs, and whether they were represented by a union. So let's start with some of the descriptives. First, up at the very top, you'll notice that the hourly wage of long-term care nurses is notably lower than non-long-term care nurses. By nearly, it's around 15 to 20%. And that does not really change by whether they are unionized or not, although the differential is somewhat smaller for the unionized groups. And these differences are also persistent across different racial and ethnic groups. So when we estimated the wage regression, what did we get? So again, I said you could roughly interpret those coefficients as percentage changes. So for the left column of numbers, those are for the people working in all settings, and the right column is limiting the model to only people working in long-term care. So for all settings, long-term care nurses controlling for everything else in the models earn nearly 10% less than non-long-term care nurses. Other significant predictors of wages include working for a temporary agency. Not surprisingly, your hourly wage is higher, which has been widely reported in the press, especially during the pandemic. And that is true both for all settings and for those working in long-term care. Management job titles, interestingly, have a lower average hourly wage, as do patient and clinical education titles, and for all settings, the other job titles. Now, why might that be? Well, these average hourly wages incorporate overtime, and nurses who are in charge nurse and staff nurse positions may be working in jobs where they are getting overtime pay at a higher rate. There also might be shift premiums for working weekends or nights, which managers and clinical educators might not be doing. So those are ways that people working in staff and charge nurse type roles can result in a higher wage on an hourly basis because they're able to take advantage of premium pay opportunities. Union representation is associated with a higher wage, about 8.4% in all settings, which is consistent with other research. And having multiple jobs is associated with a lower wage. And I will caution you, like you can't interpret this as a causal effect. It could be that you're earning a lower wage, so you're more likely to pursue multiple jobs. Or it could be that there's something else going on about your decisions about your work that are just correlated with that lower wage and holding multiple jobs simultaneously. So if we're looking at the long-term care side, temporary agency employment also has that higher earnings, as lower earnings are also found for management and patient clinical educators, but not for people with the other job titles, which includes the home health nurse title. Union representation has an even bigger impact for long-term care than hospitals, which may be in part because it's less common in long-term care. What about education and kind of the human capital variables? Not surprisingly for nurses in general, having a bachelor's degree or a graduate degree is associated with higher earnings, which would be very consistent with what we expect. We'd expect that these graduate or more advanced education opportunities are developing your skills and that employers are going to pay you for those extra skills. So those results are really consistent with what we would expect. Interestingly, across all settings, previously being employed as an LPN or an LVN, even controlling for all the other variables I've shown you so far, is associated with a lower wage. And that's something that I think we need to be attentive to, given all the discussion there is about facilitating career ladders. Career ladders are less attractive if you're going to not get as big a pay increase as you might if you'd been directly gone into an RN licensure. Current enrollment is also associated with a lower wage. Now, this might be because being currently enrolled means you're giving up overtime because you're in school instead. So again, cause and effect, we can't interpret this as enrollment somehow is causing you to have a lower wage. It could go the other way or be a much more complex relationship. So what about the long-term care settings? Well, none of them are statistically significant. Higher education did not confer a statistically significant higher wage. The point estimates were, at least for master's degree, were large, but not statistically significantly different from zero. Same for being educated in another country, being previously licensed as an LPN, current enrollment, or military service. None of those things had an effect on wages once we controlled for your demographics and for your, for some of the other characteristics and include, that I already showed you. And these are the other things that were controlled for in the model. First, for age, not surprisingly, people earn more money with higher ages, older ages, which is consistent with human capital theory, with the idea that you have more experience and employers value that experience, so they pay you more for it. Race ethnicity was not associated with wage differentials, which is really notable because older research, both in long-term care and in other settings, has found race-wage relationships. And I personally think it's refreshing to see that not show up in our model. It's nice for a change to see that not in the results. And rural nurses earn less if you look at all settings. So what about long-term care? Same pattern in general for age versus your earnings, and a much smaller negative effect on your earnings for working in a rural community or living in a rural community. So what are some of the takeaways we had from our analysis? I mean, one is that long-term care nurses are older. There could be a variety of reasons for this. Registered nurses working in long-term care might find the hours are more stable, or they might feel like they have more opportunities for leadership and for developing the organization in a way that they might want to than a larger hospital. There are a number of other reasons that nurses might move into long-term care jobs as their careers progress. They're also less likely to have the bachelor's or master's degree, and this is correlated with age. Bachelor's and master's degrees are gradually becoming more common especially over the past 20 years. We've seen a lot of movement, especially towards the bachelor's degree, but older nurses were more likely to have been educated with an associate degree as their initial education, and even with a diploma before the college level university education programs were as common as they are today. We saw the no race or sex differences in the probability of employment in long-term care, but we did see that, as consistent with prior research, that long-term care nurses are more likely to be internationally educated. And other research, interestingly published recently by Roy Thompson and colleagues, he's at City University of New York, Hunter and Bellevue, reported that long-term care immigrant nurses have more human capital than non-long-term care, non-immigrant nurses. Or actually, I should say long-term care non-immigrant nurses, which was really interesting. So that international education, maybe there's an opportunity for internationally educated nurses to use more of their human capital in long-term care. We're not really, that warrants more exploration. Prior licensed practical nurse work is associated with a higher probability of working in long-term care. The data generally has shown, especially from a study of North Carolina data that was published a while ago by our colleagues at the Workforce Center in the Carolina Workforce Center, has reported that many LPN to RN completers begin in long-term care and they don't leave long-term care after they finish their RN degree. So that kind of career ladder pathway seems to be pretty tied to the long-term care setting. And that analysis only found that 1.4% of LPNs advanced to RN on average over like a 12-year time period. So we don't see a lot of utilization of that kind of a career ladder. So a little bit on wages. Long-term care nurses earn 10% less on average, which is a pretty significant wage differential. And that may be pertinent to the recruitment and retention of nurses in long-term care settings. There aren't differences by race ethnicity, as I mentioned, which is really refreshing to see in this newer data. And there are lower wages overall for internationally educated nurses. And there is some research that finds that internationally educated RNs might be somewhat less sensitive to wage variation and prioritize other aspects of the job when making decisions about where they're going to work. Having a prior LPN licensure was associated with lower wages, but not really for the long-term care nurses. So for those doing a career ladder in long-term care, they don't really have a wage penalty for having done it. It does give them a gain. And managers and patient educators and coordinators earn less in both long-term care and non-long-term care, which also I think warrants some exploration to better understand how to retain people in these leadership roles. So that's all I have to present. I'll hand it back to David.
Thank you, Joanne, and thank you, Paula and Betty. I mean, those are really informative presentations. It actually had occurred to me, I hadn't thought about prior to your presentations that, of course, both of these both public health RNs and long-term care RNs are more likely to work in rural areas. I found the stat of 1/4 of public health RNs very startling. I mean, that was especially interesting to me. I have a starter question, I guess, for Paula and Betty. One of your findings is that like RNs are declining in, I guess, local health department settings, been declining since 2008, and perhaps it was even before then they started declining. So is your impression, I guess my question is the public health RN population itself declining, or are they just kind of shifting away from those settings into different ones?
Yeah, I mean, I think it's a mix. I think what we're finding is there are health departments when they shift, so there's this big push for health departments to shift away from clinical services, this public health 3.0 focus on population-based services. And so a lot of times seeing like, oh, if we're not doing clinical services, we don't need nurses, which, anecdotally we heard during the pandemic, those health departments really struggled because they didn't have the surge capacity that they needed because they had downsized their nurses so much. So there's been some decrease of nurse positions, but then there's also been an issue with recruiting nurses. I think, listening to Joanne's presentation, there's so many parallels between the groups, right? In terms of lower wages and, not always feeling as supported, but also often having other motivations besides wage to want to do the job. But that may be harder for retention at times as the wages kind of stay low. So we see some of that too. And then I think the third kind of prong, and then Betty can jump in, is just the lack of, I think education for nurses really doesn't emphasize this as an option for nursing, and it doesn't do a lot of training around the types of skills that may be needed in a public health setting, especially if, a portion of their job usually is clinical to some extent, but a small portion and requires some other skills that may not always be a part of their bachelor's or nursing education, entry nursing education.
Yeah, and what Paula describes as that third prong really really reduces supply, right? And so when health departments can't find when there are not people in their communities that they can hire, then they don't hire as many. And when they have fewer, then you don't end up having as many nurses in leadership that want to hire or see nurses in as really important to their agencies, et cetera. And I would add that maybe that graph showing the great decline of nurses in public health, maybe some of that is okay because as health departments pulled out of a lot of are doing less clinical services, and maybe some are regretting some of that these days as primary care settings are going through difficult times, et cetera, too. So maybe some of that was okay, but at the same time, what we're seeing is that nurses do a lot more than in public health than clinical care, and so this kind of wholesale decline has really, in our research, kind of supports this idea more and more that as we get kind of feel the urgency around assuring a adequate workforce in public health, that they do bring a lot more than clinical services.
Okay, thank you, Betty. Once more, for those in your audience, you may use the Q&A panel to ask questions. With that said, well, y'all just touched on something here that kind of links these presentations together further. Well, a couple things really. But public health nurses make less than their counterparts, and so do long-term care nurses. Joanne, do you have I know you described a lot of like why you think this is the case and that's the case, like for specific factors in your analysis, but why in general do long-term care nurses make less? And I'll throw that question also to Paul and Betty for public health nurses. What's going on here?
Yeah, I think there are two factors. I do think that there is a factor, as Paula said, there are other things that cause people to take jobs that they choose to take. So, if I'm going to use my nerdy labor economics terminology, we'd call it a compensating wage differential, right? There's something you're willing to take a lower wage because there are other attributes of the job that you like. And, as I also mentioned, hospital employed nurses can chase overtime and premium pay, whereas that's less commonly available in a long-term care setting. But people might like the environment. They might like working with an older population. They might like working with a less acutely ill population. So there may be some choice in that. But I think also long-term care jobs are kind of even more financially constrained than hospitals are. Nursing homes, are primarily paid by Medicaid programs, state Medicaid programs that often have relatively low payment rates for long-term care, and or they're being paid directly by families, and not very many families have a ton of money available to them to pay for long-term care services. So I think these kinds of factors also are contributing to the lower wages for long-term care. It's harder, even if you were a nursing home administrator and you said, I really want to raise the earnings of my nurses, you are so dependent upon these constrained sources of revenue, that it can be much harder to do than, say, for a hospital. Not like hospitals don't face constraints, but I think their constraints are less.
And I can add for public health nurses, particularly those in health departments, they are further constrained by their county wage restrictions, right? So if the firefighter in a certain job class makes X amount, then if the public health nurse is in a related job class, they are tied to one another, right? And you can imagine trying to change those systems at a local county level across different agencies is really tough. So there are some kind of external factors that really affect public health nursing in unique ways, as well as some of what you're describing, Joanne. So we look to other things regarding, other benefits, et cetera, and clearly those emerge as well as why nurses would want to do this work.
Okay, wonderful. We have a couple questions from our audience that have rolled in right now. First up, how would you change the NSSRN to include roles and functions? I am also surprised that home health care nurses are included in LTC nurses and not in public health. Does everyone agree with this classification? That's from Jan Heinrich.
All right, Jan, this is for you, Paula.
Well, I'll jump in and then I'll take the last part of the question first, because that's yes, broadly we would, because most of the time a home health kind of role is going to be more clinical than we would define as public health nursing. That could be, maybe lumped into more of a community health space, but not necessarily the public health nursing definition. In the enumeration that Betty talked about, we did do a little bit of looking at home health settings and specialties within that. And we did include those that said, which was a small number, but they said those who worked in a home health space and did say MCH specialty, because we thought that may be capturing home visiting nurses who didn't quite know where to place themselves, but were doing more MCH work. So a little bit, a small proportion, but overall, yes, we would. In terms of the function and activities, that's a great question. So the NSSRN does ask some activity questions now, but in we're doing a study right now looking at that, and public health nurses by and large they have kind of 5 activity questions: care coordination, patient care, management, non-nursing tasks, and I can't remember the other one, and then other. And public health nurses end up by and large in the other space, much more than, when we're comparing them to non-PHNs. And so we actually, even for this most recent iteration, had suggested adding on some of those larger functions that we shared in this study. So health promotion and protection. I think, research is in there, policy and advocacy being one, that those would help us get a better, isolate more specifically nurses doing work outside of a primarily clinical care space. So.
Yeah, and I think, Jan, you make a great point in terms of, home health is very different than residential focused care, like a nursing home or a assisted living facility. And so there is room to debate of, is a home health long-term care or is it not long-term care? We decided for the purposes of this paper to include rehabilitation and kind of long-term care, hospitals in the bucket of, kind of post-acute long-term care category, and home health would clearly fit into that. But one could, do the analysis and try to focus right in on nursing homes specifically, in the more residential settings. But it gets very blurry. A lot of home health is, can involve home care type services that are relatively longer term. And we did not do the level of detail that Paula and Betty did of going into looking at what age population people were working with. We really focused this analysis just on the high level job settings.
All right, thank you. And we do have another question, and I think we can fit this in. Are y'all good for one more? Great. And this, in my mind, to some extent, I'll expand on this a little bit too. And the question is, do you think nurses who start out as LPNs tend to have, less resources or opportunities starting out, like social capital type stuff, I guess, which would help explain why having started out as an LPN seems to hurt them in the wage department? I'm really thinking of this in terms of also the career ladder thing, right? They move up, but they still make less than their counterparts afterwards. I mean, what's going on there? That's kind of disturbing.
Yeah, I think that is a really interesting way to frame it. And I think actually it's probably true, right? People who are beginning in an LPN pathway maybe have had less opportunity to think about post-secondary education. They might have pursued LPN through a vocational training program or even an adult school program. And then, many LPNs work in long-term care. I would say LPNs are really kind of the bread and butter of a nursing home and are doing that kind of work and see an opportunity perhaps then to move into RN, but they're kind of starting in a different position. And to some degree, because they're staying in the nursing home setting, typically upon achieving their RN, that kind of keeps them in this lower wage working environment. So I do think that there is kind of this path dependence of how did you start in your nursing career and how did you move forward? And I don't have these data really in the National Sample Survey, but I know that other work has been done by our colleagues in North Carolina to try to get a sense of, well, what is the pathway from nursing assistant all the way through? And in nursing homes, the nursing assistant is the most common job title. So those career ladders, if to the degree that they exist, they seem to be more in the long-term care setting, but that is the setting that kind of keeps people in a lower wage category. And so we may want to pay attention to the need for opportunities for people moving through that career ladder to be thinking expansively about working in other settings if they want to. We did a project years ago that HRSA funded looking at the LPN workforce, and a lot of LPNs working in long-term care straight out said they wanted to stay in long-term care. They liked the direct contact with the residents that they had that was much more continuous and relationship oriented than in hospital. And even the LPNs working in hospitals said they didn't want to become RNs because then they'd have more administrative responsibility and paperwork to deal with. So, moving, sometimes we will say like, oh, we want you to advance up in your education. But for some people, they love the role that they're doing and are great at the role that they're doing. And I think we need to do more to value them in those roles and provide wage growth in those roles and not just say like, oh, you need more formal education to get a better wage. Because I think that really underrates the value of the experience and the passion that they have for their work.
Okay, thank you, Joanne. Well, I have other questions, but I think we need to cut off. I'd really like to have time to ask you more about that age finding, people that are old or working. That's not what I expected, but that's just me. But I think we do need to cut off to, respect people's time. So with that said, thank you, Joanne. Thank you, Paul, and thank you, Betty. It was a wonderful discussion today. And for those in the audience, thank you for showing up, and I hope to see you again in the future. Have a good afternoon or morning in some cases, I guess.
Thanks so much.
Thank you.
Bye-bye.